Welcome to Joint Effort PAs, where two orthopedic surgery PAs get real about life in medicine. From tips and tricks to professional growth, work-life balance, and everything in between. We're here to share what we've learned and what we're still figuring out. Let's get into it. We're having some technical difficulties. We're
back for
Yes.
real.
Yeah.
Well,
Right.
so this was supposed to be a rebound week.
Yeah.
And?
Well, I couldn't talk most of the week, so I don't know that it didn't qualify. It wasn't a fair rebound week. I literally showed up Monday and my voice progressively through the day,
Yeah.
began to disappear. By my last patient encounter, it was this older lady who was really hard of hearing, and their family was like, "Ooh, can you speak up? She can't really hear us."
I can't. Yeah. But you kept pushing through, which
I
actually
did.
made it raspier as the week went on.
Yeah, every time I would call my parents after work, they were like, "You need to rest your voice. Just stop talking." I was like, "I don't want to.
I can't do that.
Yeah.
I can't do that.
Yeah, and then I just sounded ridiculous.
Yeah.
I was in the OR asking for instruments. Can we
Right.
stop?
It makes it worse, though, when you have a mask on.
Oh my God.
Yeah,
And then you get coughing spells,
Yeah.
coughing fits where I was like, I'm going to try to hold it back. But as I try to hold it back, I literally feel like I'm going to throw up or something. Yeah.
Yeah. So, it's riskier. I mean, it's
It
a
is.
riskier way to live, but I'm proud of you for pushing through.
I live on the edge.
And again,
man.
like we talked about last week, that does give you some respect. I don't know if that was the right thing to do, just
Is
overall for your immune system.
It was fine. It was great.
Good.
Yeah. We had 3 OR days, which is a little more than
That's
typical
heavy.
for me,
Yeah,
which
that's
is
heavy.
what I enjoyed it. Thoroughly enjoyed it. And pretty busy clinic days. And eventually I started to get my voice back a little bit.
Nice.
So by tomorrow, I'll just destroy it again, but it's fine.
Yeah, it's fine because I feel like you're going 2 steps forward, 1 step back. So
It's still an upward trajectory.
your trend is going the right way.
Yeah. Yeah. How's yours?
It was good. So I actually started the week let me see. Hold on, let me do my math. I graduated PA school in 2007. So I'm entering my 20th year, right?
Oh, wow.
Okay.
20th year anniversary.
Hello. Yeah. So what that means though, is that I took my boards in 2007. I took them again. It was supposed to be 6 years later, but I did it 5 because the doc I was working with, he was doing his boards and we decided this is not a good idea to do it at the same time.
Mm-hmm.
So I took them again in 2012. And then 6 years from then was 2018. Then I hit the 10-year because it used to be 6 years. Now it's every 10 years. So my 10-year is going to be in 2028. Mm-hmm. So what I decided to do was sign up for the longitudinal assessment.
Yeah.
Have you done that yet?
I haven't, but I probably need to.
So I did the pilot for that 6 years ago.
Yeah.
And I recall it being not so bad, right? So for those that are going to take their boards again sometime, they are now doing, instead of going to a testing center where you have to study, crash study and then take the boards, they now do a longitudinal assessment, which it's 12 quarters. So it's 3 years, right? So for me, it's all of 26, all of 27. I will conclude at the end of 28. It's 25 questions per quarter, and they will take your best 8 quarters. And then that's your grade.
So you have some room for failure.
You have some room for failure, right? So it is if you sign on to the testing site, whatever, let's say I wanted to do, the first quarter for me is done March 10th. That is around the corner, right?
Yeah.
So I've done nothing. And I have no time in my schedule to do this. So I decided last Sunday, I'm going to pop it open, right? So that it will tell you, it'll say this next question is cardiology. Mm-hmm. You have X amount of minutes to do the question.
So is it kind of open book?
It's kind of open book, but it's on a timer and it tells you what. So I decided when I started last Sunday that I'm just going to go with good old memory.
Yeah.
That's it.
Yeah.
Right? I mean, I can look stuff up.
Yeah.
So I got through 7 questions. I got 3 out of the 7 wrong and I aborted immediately.
You were like, wait.
I aborted immediately. So I was very, very stressed out about that this week.
Wait, what questions were they specifically that you got, or what topic?
Urology.
System? Yeah.
I mean, stuff I haven't thought about. One was urology. They were all situational. One was a guy comes in with what sounded to be orthostatic hypotension and he has on Parkinson's. These are the meds he takes. What's your first line of treatment? And it was something resuscitate with fluids or check his meds or whatever. And the answer was make sure he eats more food at each sitting.
What?
I was like, what?
You're like,
yeah,
medical answer.
No, it was so, I was like, oh, this is so stupid. And then another one was like a diabetic foot ulcer. It was red. This person's like admitted for DK like multiple times throughout the year. Hemoglobin's like out of control. And the answer was, do you start IV antibiotics? Because they talked about it being right on the bottom of the foot next to the bone, or you just put like a matrix dressing on that. And I was like, IV antibiotics, no, matrix dressing.
So here's the thing with those. And this is why like in medicine, especially these multiple choice questions, not that like they're not good because you have to have a standardized form to test everybody, but a lot of it's so subjective.
Yeah.
And I feel like it's harder when you get out.
Yes.
Right. So when I was answering these questions as a student, it was very black and white because like you're answering as the textbook tells you to answer.
Yeah.
And now when I take practice tests, even the orthopedic stuff. So in school, the orthopedic stuff actually was harder for me because I felt like I had more background knowledge where like, okay, what's your first line of treatment for this patient who comes in? And like, they would give you the clinical story of somebody who tore their ACL, right?
Yeah.
So immediately I'm like, oh, this person definitely tore their ACL. I'm getting an MRI for surgical planning. And they're like, compression wrap, physical therapy. And I'm like, you just missed the ACL tear.
Yeah. So
and I got the question wrong and then I would contest it.
Yeah. So I aborted. And then I actually Tuesday, so I didn't make it very far because I couldn't stop thinking about it. So Tuesday, I set aside like 2 hours. I got my review books out. What I did was it was like, this question's dermatology. And then I did my little review of dermatology times like a couple different resources. Then I answered my question. Out of the rest of the 18 questions, I got like one wrong. So I got, I think, an 80 on that quarter.
Yeah.
But I was like very stressed out about it, which like bigger question. Why has no one in our profession made a motion to have specialty specific board exams? This is so stupid.
Because like the point of the profession or this, is the lateral mobility.
Yeah,
which I actually wanted to have an episode on that and like how my feelings are on it, which are probably very different from other people's feelings on it. But like if you should be able to have the choice, right? I
want to take a general or I want to take a specialty specific.
And like, if you want to stay specialty specific, you have to stay in that specialty. And if you decide you want to branch out, well, now you need to recertify in your boards for general or whatever.
So anyway, so that it all ended well. It's going to be fine.
Did you guys have any cool cases?
Oh yeah. So fun? Tuesday we did 2 Mishas.
Ooh. Yeah. You guys are like crushing the Misha game.
We are crushing the Misha game. So that was, again, we learned something new every time. So the first one went super smooth. The second one, it was kind of a positioning, not error, but it was just trouble positioning the implant, which again, we knew what we were doing. But
like those situations are great because like now next time you're in that position, you're like, no.
Yeah. So. And then I had 2 heated discussions in clinic this week. I'll go briefly into these because again, these could be their own thing. Oh my God. Deep breath. Just have to live it again. Okay. 18-year-old girl. She's a redhead. Not that it matters, but it does in this case. Yeah. She tore her ACL in March of 25. When she came in, like, tore your ACL, here's your MRI, we're going to schedule surgery. She's like, hey, before you guys do that, can I go play in this Gatlinburg basketball tournament with my torn ACL? And we were like, I mean, you can, but I don't know that it's going to go well for you.
Yeah, like
there's risks, not really a lot that you're putting on the line. Yeah. You can try. She goes, I'm going anyway with the team. Like, can I get in the game? She ended up scoring like all-time high for points or whatever. Great. Awesome. Amazing. Fast forward, has her surgery in March. Literally lost track of her, meaning she canceled all of her appointments after June. So she lived her senior, her 17-year-old life, June, July, August. She came back into clinic November. And we were like, wow, you're really behind.
Yeah.
You're really behind, knowing she wanted to return to basketball. So I'm talking with her therapist over the past couple of weeks, and the therapist is like, hey, so I'm going to send her back to you. See, this is beginning of February. So it's like a month ago. See where she's at. By the way, her strength test is like 60% deficit, 30% deficit, 40% deficit. So here you go. I'm like annoyed, but see the patient back. And I said to her, you want to go to this tournament again? That's March 8th. 5 weeks from now. Like, this is not necessarily a test you have to cram for this. This is a cumulative assessment. Yeah. Right. You haven't put in the effort. And she was like, well, I'm really going to buckle down. So we got a new force plate situation at our therapy. So they force plate test her, and the therapist tells me she's not ready to go back. And I told her, she's not ready. So what do? They schedule an appointment with me. So now it's the kid, the mom, and the dad. So the mom and the dad aggressively come at me.
Yeah.
Right. And just listen to the content of this conversation. The dad says, she is ready to go back. I know my daughter. She's physically ready. And I was like, okay, well, the date I have here, although it has improved since the past month, she is still at an increased risk, upwards of 20% of tearing her ACL. And that's not even on measures where she jumps and she lands on that one leg.
Yeah.
It's in other measures, just like squat and power and all that. And the patient says, with all due respect, like, I know myself. Like, I know that I will play smart. And I was like, with all due respect, if I let every 18-year-old female
who knew themselves
determine when they can return to play. So the doc that I work with, we were talking about it, and I was like, am I crazy? So I said, listen, everyone in this room, this is a family decision. Like, if you want her to go back to play, you are assuming risk.
Yeah.
Okay.
Like,
you are asking asking my opinion. I'm telling you my opinion. You don't like the answer.
Yeah.
And you're going to do what you want anyway. But I just want to address the fact that you're not ready. And the mom then gets into like, you told me we would be better within 9 to 12 months. And now I want a refund from my basketball season. And I was like, oh my God.
What in the world?
I know. It was like a whole thing. So anyway, so I ended up writing them the letter that had just said like, and by the way, the brace that she played in, she's been in practice. The brace she's playing in is like a hinge knee brace. Okay. Like it does nothing for you. Like you haven't even gotten your custom brace yet, right? Anyway, so she says, well, if you don't remember, I played in this tournament last year when I tore my ACL. I was like, I do remember. You told me you scored like all season high, but you had nothing to lose.
Yeah.
Like you weren't going to re-tear it. Yeah. This is an investment you're going to be protecting right now. So then the dad ends and he's got like mean mug. He ends and he says to me, he goes, I know you don't know my daughter, but I've watched her in practice and she does not have a deficit. And I was like, okay, where do I sign?
Yeah. Like, what do you want me to do?
Again, I'm like annoyed by that. But anyway, so I'm just waiting to see how she does. Second weird interaction I had this week was a workers' comp lady. God, we signed her up for surgery because her knee was popping. She's 57. Okay. MRIs were completely normal. We get in there to do the most minimal lateral release. Okay. Most minimal. I was not there. It was not my day.
Wait, was this Wednesday?
No, this is a year ago.
Oh, okay.
But yes to that one.
Okay.
But so did this most minimal lateral release. They ended up doing a meniscus repair because she's 57. She had a meniscus there. She rehabs terribly, right? Now, again, why do people's knees pop when they're 57? A little bit of OA, but quad deconditioning. So she's in therapy now from March of last year until now. A month ago, the case management worker was like, hey, is she going to get any better with therapy? I'm like, let's do an FCE. So I walk in to go to the FCE, which is usually the rating visit. And I walk in and the husband was like, I want to know who in this room is trying to work against my wife until the visit started. And I was like, gosh. He goes, I understand that you chose to cut off therapy so my wife cannot improve. I was like, sir, she's done 78 visits of therapy. And from the surgery, she is fully recovered. The quad deficiency that she has because she's 57 and because she came into this not well, that's not what we're talking about here. The FC. So anyway, the FC is like, can lift 25 pounds, can go overhead, can carry 60. And he's like, but she can't drive. So I'm like, oh my God, we gotta get the nurse case manager in here. And it just was one of those things. Yeah, she can't sit in one position for too long. So I said, well, how long have you sat in a car? She goes, I don't know, honey. When did we go to Aunt Linda's house? How long was that? He goes, it's 3 hours. I said, perfect, 3 hours. You can travel 3 hours. She goes, but now without breaks. Fine, you can have breaks. But it's gonna take me all day. I'm like, oh my God. It was so bad. I had a student with me too. And the student was like, are you okay? I'm like,
no, okay. I'm not. Yeah.
But anyway, no, it was a whole ugh.
Oh man, those are painful.
It was painful, but I mean, again, I don't know if this is a growth moment or this is just what happens as you do this more. Completely unaffected by that for the rest of my day. I mean, I rebounded very well from both of those.
And like those things, they personally affect you. When I look at them from the outside, though, I'm like, there's no reason that Beth should feel anything for this because this is not on you in any way. But you still initially, especially, right? Like you said, the later in your career, you take it less personally. But
the psychology of these visits is just so insane. Yeah. Like I know the ACL dad came into that visit and he's like, I will leave and she will return to play. And he will feel good about that. He will not care that I'm an expert in this, whatever.
It's never going to end well for you, because either she'll do great and they'll be like, see, you were trying to sabotage us and hold us back, or she'll re-tear it and it's still your fault somehow.
She will re-tear it and she'll go somewhere else because she won't look at me when she re-tears it. But anyway, what I said to the ACL family before I left the room, and I was like, I said to the girl, I said, do you understand that I am on your treatment team and I am, despite what you think, trying to do what's best for you? Like, do you understand that? And I look at the parents, like, do you understand that?
Yeah. You do not seem like it.
You do. Yeah. Anyway, so that's
wild to me.
Yeah.
Okay. So
that will parlay a little bit well into our topic.
Yeah. We're going to do some myth busting, some common misconceptions, clinical and
otherwise
PA related. Otherwise, yes. Actually, myth number 1. This segues great into.
Yeah.
Okay, Beth. I heard that you'll never be the same after an ACL tear.
Yeah. So So speaking of ACL stuff, and again, return to play or whatever, I will hear I'm never the same after I tear my ACL. I'm never going to be able to do anything again. This is like,
they hear it like when it happens to one of the NFL players, they're like, oh, they're done.
They're done. Yeah. So, I'm going to say that's a myth.
Yeah.
The reality is that athletes or non-athletes can get back to higher level activity. I mean, this is not a surgery that you do that you're now handicapped for the rest of your life. Is your knee going to be different? Yeah. It's not going to feel like you never tore your ACL before, because there's surgery that needs to be done to fix that. But can you run, sprint, cut, jump, play competitive sports, contact? Yes.
Did you not play in a soccer game this week?
I did. Okay. Yes. That was my weekly highlight. That was also part of it. I played in my soccer game this week. I was thinking about this morning, 8 and 9 years after my ACLs.
Oh, see?
Yeah.
You can be the same and continue to level up after your ACL tear.
But no, the truth is about ACL tears, and again, this hits home this week. I have another situation, which again, I should have brought up, but I didn't. My daughter's friend tore her ACL on Saturday.
Oh.
Okay. Just sidetrack for a second. I examined her. I'm like, hey, I think you tore your ACL. The trainer there told her she didn't. So the parents were like, oh, so she didn't. I was like, no, I think she did. Mm-hmm. So call me, let me know. I'll get you an MRI. She ended up going elsewhere. Texted me Thursday. I was like, oh my God, she tore ACL. And I was like, no shit. Yeah. But anyway, and it was the whole thing. The mom was like, oh my gosh, she's never going to be able to go back. Here's the deal with ACL tears. They suck. Mm-hmm. They suck. Even if you do everything right, if you are like conditioned and you're strength training and you're, doing all the things to take care of your body, they just happen. Mm-hmm. And they are sometimes non-contact, which means guess what? It's nobody's fault, right? Yeah. Sometimes they're contact. This girl's was. The way that you recover from an ACL determines your ability to go back to play. And if your knee will, quote, be the same. That's how it is.
Probably mindset too.
Yeah. If you are not going to rehab that correctly, you're not going to dive into that and really do everything you need to do. If you rehab at 80%, 70%, it will always be the weaker leg. It will always be, at risk for injury. That's the physical part. The mental part is also huge. Like I was looking up the statistic not too long ago. So I was going over this with a patient. The psychological factor for return to play, it's a high percentage of patients who do not go back to return to play because of the psychological readiness factor. Yeah. It's not necessarily they're not testing that they, are not ready to go back. It's the psychological part.
Psychological readiness is like huge. Have you ever scraped the shit out of your shins doing a box jump and never been able to do a box jump again? Because I have.
Yes. So that's funny you say that, because when I attempt to do box jumps, I will go through this whole thing. It's like when you go on a diving board at public pool, you go to the end, you're like, I'm ready. And then your body won't go.
Yeah, you can't physically do it.
Like my upper body goes and my lower body won't move.
I literally will try to jump, and then the front part of my upper body just leans forward, and I fall forward onto it. I'm like, what?
Yeah. And again, this goes into the second myth of this two-parter is that all physical therapists can do the same quality of work. Hannah, true or false?
I have to say that's false.
That is false.
Seen it firsthand many times.
I know.
And it one physical therapist, just like you specialize in sports stuff and hand and upper extremity, you have your strengths and your weaknesses. Yeah. It's kind of like going to a general orthopedic surgeon in a little tiny town for everything. versus someone who's super specialized in it. So, we are fortunate just in the area that we live in that we have highly specialized therapists for our baseball people.
Mm-hmm.
You have specific people that you rely on for your ACL rehab. You have our shoulder team. Like, there's people who know their stuff about it. And I will tell patients all the time, like, if they want to go somewhere out of convenience where I don't know the therapist, like I'll give you the benefit of the doubt.
Their neighbor's a therapist. Yeah. My brother's a therapist.
Those never work out well.
Never work out.
Like, oh, my daughter just went to
how about
PCL. She'll give me some exercises.
How about I'm a therapist?
Yeah, like I'll do my own therapy.
Yeah.
Yeah, good luck. Good fucking luck.
Yeah.
But I'll like give you the benefit of the doubt, right? But like, it's probably not going to go well. And the second it doesn't, I'm going to switch it up.
So I think there's a lot of variables that go into returning back to play after you have an ACL tear. And don't get me wrong, especially since my daughter's friend, again, is living this right now. It's a huge blow. Like that, it's a year, no matter which way you cut it. From the date of injury, from return to play, it might even be more, right?
Yeah.
So for my daughter's friend, it's her social, it's her physical outlet. Mm-hmm. It's, what she does every day. Like, what am I going to do with myself now? So will you be the same after an ACL tear in regards to sports? If you put in the time, effort, and you have the mental toughness, then I'm going to say, but not, it makes you, well, that's why we'll tell patients, you're going to spend the next year in therapy doing way more dedicated stuff than you ever would have done prior to this. So you should, if you do it right, come out better on the other side.
Yeah.
But don't tell me who you want to rehab you. I will tell you who I want to rehab you.
Mm-hmm. Yes. Yeah. I will tell you what you need, and maybe not what you want to hear.
Maybe not what you want to hear. Yeah.
Okay. Anyway. Myth number 2.
Yeah.
Arthritis means stop lifting / running ruins your knees / insert any type of thought about, oh, it hurts and I have this disease, so I must stop being active in said ways.
Yes, I can't squat anymore because I have, quote, bad knees.
Yeah.
I hate that.
Hate it so much because data shows that properly performed squats are very protective, very joint protective.
Yeah.
And I think it was, I probably got on this kick many years ago from your doc. I believe there was squat challenges happening at one point.
Oh yeah, that's
right.
True.
Where
we
like
go back to that.
You guys were doing X number of squats a day, and just like randomly in the middle of clinic, it was like squat time.
Yes. Why don't we do that again?
I don't know. Should we go back to squat days?
Yes.
Monday squat challenge.
Yes. Actually.
50.
Yeah. Oh my God. Easy. Come on.
Yeah. Like, can we up this?
Can we up that? Yeah, we should do that. No, I hate when patients will come in and they'll tell me like, all right, well, I'm going to send, let's say, and again, this is when they start tuning out. I will send you to physical therapy. I know you have arthritis. No, I can't squat. I have bad knees. I can't do that. Well, I understand that. But if you see a physical therapist, they can actually teach you variations on how to do the same things to fire your quads and your glutes, where you actually will get the benefit of that. But it's a hard sell because it's just such a stigma that you have arthritis, therefore you can't.
You need to improve your muscular strength.
Yes.
Muscle is like, strong muscle is extremely important, especially as you age. You're going to improve the stability of your joints. So you're going to have more evenly distributed load bearing. And then also just the idea of like bone density importance with it.
Yeah.
As you age.
Yeah. So muscle mass is the key to longevity, and you can't get there not moving. Yeah. You can't do it.
Or not squatting.
Yeah.
Why is everybody not squatting? Why are we not doing squats right now?
I don't know.
As we record this.
No, but
I'm going to do squats later today.
Sarcopenia, which is the loss of skeletal muscle strength and function, that is linked with active deceleration of just vitality.
Like those words you just used, it's like disgusting, Sonny. Sarcopenia, like
I know.
If somebody told me I was sarcopenic, that's like
I know.
I'm done.
I know. Like I'm gonna second guess my life choices. But if your muscles are stronger, you're not gonna fall. If you don't fall, you're not gonna fracture things. You're not gonna lose your independence. Surgical outcomes are not going to be poorer. So there's so much truth in movement and muscle gain, and arthritis is not a deterrent.
Yeah.
Okay.
Yeah.
Okay.
All right. We'll briefly go over these ones. These are kind of some ortho clinical related ones. Baptism meniscus tear always needs surgery. Wait, I got an MRI and it showed that I had a meniscus tear. Why don't we need to fix it? Why don't you want to fix my meniscus tear? Why do you want me to suffer?
Yeah, you guys, why is there not any alcoholic beverages to go over this? This is such a big one, and buckle up because I got some thoughts. Okay. when a patient comes in, and I had this conversation on Thursday, I have a patient that has terrible patellofemoral arthritis. He also has, never been diagnosed with patellar maltracking. He comes in, his knee is huge and swollen. He also fell on a hyperflex knee, right? So his MRI scan shows huge effusion, patellofemoral arthritis, partial tear of his PCL, and this maybe degenerative tearing medial meniscus. So he has the report. He's got it in his hand when I walk in the room, right? And he's like, oh my God, I know. All right, just lay it on me, doc. Tell me when I need the surgery. And I was like, for what? He's like, my meniscus tear. Do you hurt on the inside part of your knee? He's like, no. Okay. His knee is swollen, right? Because he's got kneecap arthritis, and he can't flex his knee all the way because he partially tore his PCL. Yeah. I was like, listen, I can explain your symptoms. And then I went through all that. He's like, so what about my meniscus tear? Is that going to heal? I'm like, dude, I do not even think that's playing a role in what's going on here. Yeah. Like, trust me on this one. I just don't think so.
But they've got it circled on the MRI report.
Circled. Yeah.
Highlighted.
Now let's take another scenario. Very advanced medial compartment arthritis. Patient will come in because they had a knee scope 10 years ago on the other knee. Doc, it hurts right on the inside part of my knee. I need my MRI. I know it's my meniscus. So I'm ordering the MRI because it doesn't matter what I say. Yeah, right. I'm like, oh, wow, I will get the x-rays. I'm like, wow, this is pretty advanced arthritis here. Get the MRI. It's got a meniscus tear, and I'm not necessarily recommending surgery. He's like, I don't understand. I'm like, well, your arthritis is so profound, and your meniscus is like, again, it's a degenerative signal. Like, is it or isn't torn? And also, do you have any clicking or locking or catching? He's like, no, it just hurts when I stand. Well, I'm not going to recommend surgery there. Yeah. And also, will it heal on its own? Probably not.
No. You are now of the subset of arthritis treatment patients.
Yeah. And again,
and that's such a depressing stage.
No, it is. And if you're not ready to hear that, it's not heard. Yeah. Right. Yeah. But not all meniscus tears require surgery. That's not equal to that's because they heal. Yeah. That is not true. Degenerative tears, traumatic tears, age-related mechanical symptoms, all of that plays a role in what our recommendations are.
I feel like I did really, really good when I worked in urgent care about like my 20-second spiel on the 52-year-old who comes in with medial knee pain and they think it's their meniscus.
And it's not like it's not. It might be.
Yeah, like it is. Probably if we get an MRI, I bet you will see some meniscus pathology, but like we're not going to address yours the same way as 17-year-old Johnny's.
Yeah, who has a bucket handle
hair.
Yeah,
and they're like, wow, how ageist of you.
I know. Yeah. Why, you don't think I'm young? You don't think
like, wait, I'm not active? No, I walk for my job.
I walk for my job. I do all the exercise. Yeah. No, but not all meniscus tears are created equal. And there's so much that goes into recommendation for treatment. Yeah. And again, this is an underlying theme of today. Like, you're asking our opinions because we're the experts on this. It is not necessarily true that if you ask our opinion, you don't like that answer, you're going to go across the, across the parking lot and get another opinion. My dad's 72, 3/4, something like that. He's got knee pain. He had x-rays done wherever he lives, and he sent them to me. And I'm like, dude, you have no lateral joint space. Yeah. So gets an MRI and they tell him his meniscus is torn. I'm like, send me the report. The report says macerated, so it's shredded. Yeah. It's shredded. So he says, they're recommending surgery, meniscus, whatever. I was like, or gel. Yeah. And he's like, no, they didn't even talk about that, just surgery. So long story short, he has a surgery that he tells them in recovery, tells my mom, oh yeah, it was really torn. There's nothing we can do. We just debrided it, and he'll probably need a total within a year. Like, that is common.
You knew that before you went in.
Yeah, but that is common practice in the area. Yeah. I have patients I've lost here and have gone somewhere else, had their meniscus debrided, and then had a total a year later, and they just don't understand.
Because I think they see that as like the ultimate fix. They're like, oh, if you don't want to operate on this like circled pathology I have in the MRI, it's because you want me to feel like you're not doing the most that you could be doing, rather than like taking it as, well, maybe you are approaching it from like an action, like a more holistic, not holistic, but like you're looking at the whole picture, perspective. And maybe whoever's seeing over there isn't doing like a really thorough physical exam, and they're just reading the MRI and they're chat GPTing the
But response. Also, I think patients come in wanting surgery to fix their problem, meaning I have a problem. You are a surgeon. Why won't you fix it?
Yeah.
But don't really want to listen to the whole like, hey, the risks of surgery is if we go in and we do a meniscus repair on you who's like 50 pounds overweight, you're not going to be any better off on the back end. And I'm sorry that it bothers you now, but it's probably been torn for a while. But this is the start of the breakdown of your knee.
Yeah.
And then you go to the next patient. Well, I have a meniscus tear and on my other knee, I went to so-and-so and they fixed it and my knee feels great. Yeah, but that was 10 years ago.
Yeah.
And that's different now. Like they just don't want to hear that. And they will shop around until someone tells them what they want to hear.
Dude, that's TFCC tears for us.
Oh yeah. Yeah.
I hate the TFCC. Ugh.
Yeah. All right.
Rotator cuff tears, I'm going to kind of lump that in with what we just talked about. Same kind of thing. Like, yeah. Moving on.
Rotator cuff. We'll do a rotator. We already did a
We've done rotator cuff stuff. We've done the progression. Yeah.
Let's go to some hand stuff. So Hannah, I have carpal tunnel and it's caused by typing.
Yeah. You think you have it because your job makes you type all day and therefore I need to make you not work anymore so
Hannah, fix my carpal tunnel because I get it from typing and now I can't work. And by the way, because it's my right hand and it's really symptomatic, now I have it in my left hand. And it was directly caused
because I've been overusing my right hand so much and I had to stop and now it's compensating.
So is carpal tunnel caused by people who work?
The people who work? Well, no, because trust me, I see plenty of people who don't work who also come in complaining of carpal tunnel. No, it's like a super common misconception. Carpal tunnel is caused by typing. It is not caused by typing. There are certainly certain like careers that probably have a higher prevalence of it than others, like laborers, that sort of thing. But a lot of it is genetic, anatomic, like your carpal tunnel space is just smaller. There can be like other medical conditions contribute to it, poorly controlled diabetes, thyroid issues. People get it during pregnancy, just repetitive activities. It's not just related to typing.
And
your typing didn't cause it.
Right. Part 2, can you go back to typing if you have carpal tunnel?
Yes, you certainly can still continue to type. People ask me that
all the time.
Every single day. They're like, how, like I have to quit my job, right? I have to stop working on a computer because I have carpal tunnel. I'm like, why don't we just do a carpal tunnel release and then you can go back to typing in a week?
Yeah. But Hannah,
if we do an endoscopic.
But Hannah, I don't have carpal tunnel because I had it fixed 20 years ago. It can't come back, right?
So theoretically, the ligament itself is not going to regrow itself. So that is not what's happening. But sometimes if maybe it was like a mini open carpal tunnel and it wasn't a complete release, that can cause you to still have recurrent or worsening symptoms afterwards. Scar tissue formation there, but there's plenty of other things that cause numbness and tingling in the hand that aren't carpal tunnel syndrome. So then you have to start thinking about what if this isn't even carpal tunnel related anymore? And I'll inject those people to prove to myself and them if it is or is not coming from carpal tunnel recurrence.
But I bet you hear that. How many times a day do you hear that?
It's high.
Yeah.
Yeah. Your carpal tunnel is not caused by typing. Type away. If it were caused by typing, I would have it right now from typing all my notes and I would have had to quit my job a long time ago.
Yeah. Yeah.
So
now we use steroid injections a lot. We do them intramuscular, we do them interarticular, we do them intertendinous. Now, how many times a day will you hear patients tell you, oh, I can't do cortisone because it's going to ruin my joint?
I do have some people who will voice that concern to me. Like I heard steroid injections are bad for you, so I don't want to do them.
Yes, I think that's more accurate.
So my caveat to this is what are we injecting it for? Like, let's think about it from this. So I have differing opinions probably on steroid injections than I did even 5 years ago.
Yeah. Mm-hmm.
And I'm sometimes the anti-steroid injection person now. So if it's like a tendinopathic issue, there's definitely evidence that repeat steroid injections can cause harm. Like I tell people we'll only do 2 or 3 trigger finger injections because that risk for flexor tendon rupture goes up. Tennis elbow, I don't like to inject it more than once for sure. Sometimes not even at all. Like I don't think it's a great option. But intra-articular injections for arthritis, I will tell the person, I don't know if this is the right way to explain it or whatever, but this is what I do.
Okay, here we go.
I'm like, okay, you're worried about your joint being destroyed. Like it is, and we are buying you time with this.
Yeah.
So while I do not think that this small dose of steroid, if we space it out properly, every 4 months or so as needed, is going to exponentially increase the rate that your joint wears down, it's already worn down. And right now we can either say we're going to do this like really big, arthroplasty, or we're going to buy you some time with steroid injections. Either way, your joint's not going back to what it was when you were 20.
Yeah.
So we either choose to do them for pain relief or not.
Yeah.
And you hurt.
Yeah. I will have that conversation too, because they're like, oh, steroid. I don't know. I had one 3 years ago and I was told only 3 in a lifetime, which again.
Yeah. Where did that come from?
I don't
3
know.
in a lifetime?
I know. Literature will suggest that you should minimize that. But like, here's the deal. You see someone for knee arthritis, whether it's mild, moderate, or advanced.
Like, are you worried that my injection for your knee arthritis is going to cause knee arthritis?
I know. Well, that's what I will say.
Yeah.
So I will say, yes, repeat injections at a high dose and at increased frequency is associated with accelerated cartilage degeneration. However, and overall worsening the arthritis progression. However, when you safely, AKA no sooner than every 3 months, giving that like true washout period, staying at a lower dose, that's okay and that's safe. Now, let's talk about AC arthritis. AC arthritis in a non-weight bearing joint. Mm-hmm. Some areas of the body will get so arthritic that eventually that little movement that happens there stops happening. It kind of like fuses.
Yeah.
Hello, AC joint, right?
Yeah.
So the risk benefit, we can inject your AC joint. Let's say it does worsen the arthritis. Wait it out, my friend, because then maybe your AC joint won't hurt.
Fused. Yeah. You fused it.
So there's so many caveats to like, will you or won't you? Now let's go back to tendon injections. There is literature that suggests that if you inject lateral epicondyle, rotator cuff, patellar tendon, like you will over time degrade that tendon.
Yeah.
And even next step, when you go to fix that, the chance of that healing correctly and not failing is actually less if there was exposure to steroid injections, not in like 3 months, but in the history.
Yeah.
So tendon injections, you have to be way, way, way more careful with. Mm-hmm. But again, risk benefit, right?
Yeah.
Am I going to inject a lateral epicondyle on an 87-year-old who likes to knit all day? Yeah, I am.
Yeah,
I am. Right?
Yeah, because we're not going to, your chances of improving with PRP or any of the other things, pretty minimal. Like, I don't think your tendon's going to have great healing potential regardless. So let's do it.
Now, other myths, right? Steroid injections. I'm not going to do that. It's going to make me gain weight. How many times have you heard that?
Oh my gosh. Yeah.
There are things that happen. And if you don't go through your spiel for like side effects of steroid injections, it's always that person it happens to, AKA facial flushing, right?
Yeah.
A little bit of discoloration at the site. You just don't
cortisone flare.
Yeah, cortisone flare. I had one patient who I injected 8 weeks ago. She just wrote in saying, hey, my blood pressure is really high. It's from your steroid shot 8 weeks ago. And I was like, it's not. It's not. And again, I wrote her back. I was like, that is a side effect, but it is so transient. We're talking 3 days. If it's 8 weeks later, it is not the steroid injection.
You may want to go talk to your primary.
I have another lady who I want to inject her knee and she's on Eliquis and she's got a lot of other things going on. She's like, I need clearance from my cardiologist.
Yeah.
If you're making the rules, I will follow the rules.
Yeah.
But if you ask me, I would proceed with
that.
It.
I'm not concerned, but we can be as thorough as you would prefer.
Yeah. And I'll also have the patient that it will cause a little bit of hyperglycemia. And again, it's like who you don't tell it to that they're like, oh my God.
Yeah. Like, okay. Let's shoot into some PA life common myths, because I feel like we might expand on this might take some time to unpack. Okay. I hear this and it makes my skin crawl and I writhe when I hear it.
Okay.
And I've had multiple people say this to me when I've asked them what has made them transition. Like maybe they wanted to go to med school or something and then they changed their mind and wanted to go to PA school.
I see where you're going with this.
Myth: being a PA means less work and better work-life balance than the doctor. Sometimes a myth, sometimes not. I will give it that caveat.
Okay.
But I don't think that's fair to say as a general statement.
Okay. Do you get annoyed because it implies that you chose the easier path? Or from the perception of others?
Yes, partially. But I also just want people to understand that like that's not necessarily true.
It's not true. I think it also goes with the undertones of like, what made you decide to like wuss out and not go to med school? Yeah. You decided to do the easier thing. Oh, that's cute.
But it can be true, but it also can be true for like doctors choosing their specific specialty. I went into this because it offers a better worth. I went into dermatology because I get to go home at 4:00 every day and I don't take call. Mm-hmm. It depends. Like we all went to PA school. We all have the same degree. I could have chose to work in dermatology.
What was your second choice, or when you went to PA school? And we talked about this. I think for you, it's always been ortho, but what were you also entertaining? What other specialties?
Emergency.
Yeah. I mean, those, me too.
I mean, like, those are the only options, right? Like, how else am I going to get my high? So,
okay.
Yeah.
But I think that, again, I think it's the assumption that you went into PA school because you couldn't hack it in med school, or you didn't want to be challenged, or it wasn't as hard, so this fit better for you. But that's really funny because you also are chasing two specialties that are high demand. They are fast paced. They are associated with higher stress levels.
So I think this is just highly dependent. I think it can be true, but it also doesn't have to be true. Mm-hmm. Yes, you might have better work-life balance as a PA in a certain specialty than being a physician.
Yeah.
But if you want to work in a role where you have a high level of responsibility outside of like your basic charting, it's not necessarily going to be true. Yeah. And I like that for me personally. And that's probably why it bothers me when I hear it. 'Cause I'm like, this is honestly why it bothers me. I'm like, do you look at me and think that I don't work hard enough?
Yeah. Well, again, that's what I'm saying. There's an undertone there.
There is an undertone. Yeah. This is a personal problem.
No, or let's say you're in a room. And again, this might just be me, where I had this week. Again, another thing I didn't unpack. I had a lady who we operated on from South Carolina. She had a full thickness rotator cuff tear. It retore. She currently has underlying C5, C6 issues. We told her prior to the surgery, this is going to get in your way. You're not going to optimally rehab your shoulder because of your neck. Fast forward to now, it's like 3-4 months later. She's like, my shoulder's killing me. It hurts so bad. I just sit here and, we're communicating to her via South Carolina. So I'm like, get some lab work, get your neck looked at. So she comes back in. She wants to go over her MRIs over the phone. So we kind of did. And again, we're like spot calling her. So she's not really like tuned into what we're going to say. So she comes in for her shoulder aspiration, which again, she had to come in for that, and wants to talk with me or the doc to find out, quote, what's really going on. Mm-hmm. So this was like a double booked aspiration appointment. So I walked in. I was like, oh God, that's going to take a while. So I was like, listen, from the top, this is your MRI. Let's go over this. It is retorn. It's probably retorn because you can't activate and get your arm over your head because your neck is like stalling you. Oh, that's funny you said that. I'm scheduled for a fusion in a couple months. Do you think that's going to help? I'm like, yeah, it's not going to heal your rotator cuff, but yes, it's going to make your rehab better. So I spent so much time talking about how the neck's related to shoulder, how the shoulder will re-tear when the neck's not optimized. She's got a ton of synovitis in her shoulder. Maybe it's an infection. I don't know. We need to aspirate it before we even talk about anything. And she was like, oh my God, you did such a good job explaining. Have you ever thought about going to med school?
Okay. Wait, I was really happy for you for a second.
I know. Well, because understand, she thought that level of explanation could only come from the physician. Hence, when she drove up 3 hours, she wanted to say, can the doc pop in?
Right.
Yeah. So like, I just think there's the undertone of like, you're only doing this.
Yeah.
It's like you're only running the half marathon because you can't do the full.
Right. Yeah. Like, why don't you do the other half?
Yeah.
And this is nothing against, like, I have a ton of respect for the docs. Like, they go through far much more training, and my expectation is that they know more than me and that we can, I can bounce things off of them. However, that doesn't mean that like I can't also do a thorough
But
job.
In your specialty, you should do a thorough
you should be able
job.
to. Yeah. Like, I have the expectation for myself that if somebody sees me for a hand issue, I should be more proficient at explaining things than a general practitioner.
Yes.
MD.
Yes.
And that's not anything against them.
Yeah.
I mean, if somebody came to me asking how they should get their A1C down, I mean, if I know, right? I'm probably going to fail my friggin' 10-year board research at this point.
You probably will if you try to do it on a Sunday, Hannah.
Yeah. So I do. So back to one of our other myths, you did PA school because you couldn't get into med school.
Yeah. No.
Yeah. No.
It is a choice.
Yeah.
In fact, I chose PA school because I was back and forth between like a psychiatry, neurology, ER, and ortho.
You wanted the special, you weren't
arguably,
sure.
I do all of them right now.
Yeah.
But I didn't want to commit to like one thing.
Yeah.
And I also didn't really want to spend, X amount of life in school. Not to say that I couldn't. It's just not what I wanted to do.
Yeah.
But I find myself like explaining that to patients.
Yeah. Yeah. Like, how do you explain that in a way that doesn't sound like, I don't know.
Yeah.
I tell people, I'm like, well, I didn't decide to go back until I was like late 20s, early 30s.
Yeah.
So like I would have, it made the most financial sense for me too. Plus I like working on a team.
Yeah.
And that's part of it.
Yeah.
I think so.
But also the need for you to justify yourself is ridiculous.
Yeah, there's a lot. I was telling you before we started, I had a patient several weeks ago who like went through the whole visit. I felt really good about it, did a thorough job, worked up like, multiple things at the same time for this patient's mom. And he was like, wow, like, so when are you going to med school? I was like, never.
I know, but that's because the association with higher level thought and discussion, you must be a doctor. Like there's just, that's just what it is. I feel like the general, population has placed PAs in the healthcare field. Like they get who we are, I think, but it's a generational thing. Yeah. Like older, like my grandma, she has no idea. Yeah. Like she doesn't know.
She's like, myth number 1, PAs just follow doctors' orders / are assistants.
Yes.
True and untrue.
Yeah. Yes.
There's a little bit of both.
But again, generationally, I think if you were to see a 20-something-year-old right now, I think they get what a PA is.
Yeah.
But again, like you said, another myth, PAs are just people that follows doctor's orders.
Yeah.
And it depends.
It does depend. I mean, like I'm not going to I'm not going rogue over here. I'm not like.
No. But I have met
opinions.
PAs that are just not independent thinkers.
Yeah.
And if your role is such that you work with a physician that doesn't want you to be, then it works out. But I've also met PAs that work completely independently and then check in with their docs like on a higher level, but just really infrequently. Yeah. So it's, PAs, it just depends.
If you're going to be seeing your own patients, you have to be an independent thinker. I can't be like stopping in the middle of clinic to ask about every single person.
I know.
So yeah, and just assistants, I mean, I don't know, that gives a negative connotation. Just assistants.
It makes me feel
I am an assistant, but like I do more than that too. Why is the word just got to be in there? Like, why can't I be an assistant and not be like?
Do you have like a 20-second like explanation to patients
on like the difference between PAs and physicians, or what I do?
Or like so what did you do? What did you do? Oh, you were there in the OR. What did you do?
Yeah. Oh, like when I explain that to them, well, rather than just assisting and like, oh, hold this and do this right now, cut here, right? You're anticipating, and your steps back to front, sideways. So, you could do it in reverse, yeah.
I will tell the patients, they're like, so you were there? Like, what did you do? And I will joke now. I'll say, well, I kept the surgeon in line, make sure he did his job. Somebody's got to do that.
Yeah, and they're like that joke. Yeah, cute and sweet. They like to hear that.
What did you do?
But really though, what did you do? What did you do?
No, I like I said, it kind of depends on the patient. Like,
do people
generationally, I think they just assume that you are what you are. So we did a couple clinical scenarios and then a couple PA scenarios. What about like you personality
scenario? One? I put this in here because ChatGPT thought of this one. This one's just funny because the myth says we're both super type A, but that's not a myth. That's a fact.
But okay. Do you think you're super type A?
Yeah, I do. Okay, but like here's where we get down to the reality of it. Are we super type A here? And then what does outside of here look like for you? Because if you see how my brain has things, working for our schedule and all that stuff, it looks like I'm super type A. If you walk outside right now and open the back door to my car, you'll be like, what the fuck?
Okay, that's really, so I'm going to ask you a couple questions. Do not delay in your answers.
Immediate fire.
Response. Okay. If you pull open one of your drawers, are your clothes folded or is it just shoved in there?
Shoved in there.
Okay. Yeah. Me too. Yeah. Your laundry room situation. Is there like an overflowing? And when you have clothes that are done, are we folding them or are they all over the place and on the floor?
I live on top of my dryer.
Me too.
And I pull from it.
Yeah. Me too. So will you actually fold clothes?
Sometimes I just throw them back in the dryer for 10 minutes in the morning to de-wrinkle them.
If I were to drive in your car right now, okay, and I'm looking at your windshield, is there like fingerprints, messiness all over the place, or is it like pristine?
I haven't washed my car in greater than 6 months.
Okay. Yeah, me too. I will look over on the passenger side and I still see the footprints from my kids have their feet up there driving home from a soccer tournament, probably last year.
Yeah.
I just won't
I
clean
have some empty Dunkin' cups on the passenger floorboard. There's some stuff going on in there.
So how can you be super type A at work and then like completely the opposite afterwards? Is it just balance?
I think it partially balanced, but also where you want to put your energy into, like what drives me. And it's not making sure my bed is made every morning.
Yeah. Do you make your bed every morning?
No.
Will you go to spurts where you will?
No. I mean, maybe like if somebody was coming over and I wanted to like make them seem like I have my life together, I might make my bed. I don't know.
Like light a candle? I don't know.
Yeah. Like
my house always smells like this.
I'll straighten up, but like, no, because why would I do that? Like, I'm just going to get back in it.
Do you think though, part of the answer here is also because being type A all the time is just not sustainable?
Yeah, you can't do it in all aspects of life.
Have you ever?
Some people do though, I guess.
Yeah. Have you ever had a situation where it bleeds over, not the type A into the outside life, but the outside life messiness bleeds over into work?
Yeah. I mean, I am not like, there are certain things that I am type A, but like in my own chaotic way. Like you've seen like my desk space area. It's not super, I throw shit everywhere. Like all the papers, my team constantly cleans up behind me and like straightens the papers. Yeah. Yeah. Okay. I just throw shit everywhere. I'm like, it's like a tornado.
Yeah. No, my book bag, even my organization, my book bag is just like paper shoved in there. Just papers.
Yeah. So is mine right now. I've got a bunch folded up because I'm ready to shred them. And
but if this were a project for work, I would have like folders and color codedness. But my life in my book bag is just shoved papers.
Thank goodness for Google Drive and Google Calendars.
It's true that.
Okay. Yeah.
Looking at something that caught my interest about like different ways orthopedists explain things and what they say versus what they mean. I would love to talk about that one of these times. When I say things like, "Ooh, this may require a tertiary facility," that means you are crazy as fuck, and we are not going to treat you here.
Oh, yeah.
There's just ways of saying things.
Histrionic.
Yeah.
Love that word.
Yes.
Yeah. We also need to have a guest back on soon. We've been like,
we've been toying with that. While. Yeah.
Yeah.
Okay.
All right. Till next time.
All right. Bye. Thanks for tuning in to Joint Effort PAs. If you enjoyed this episode, be sure to subscribe, leave a review, and share it with a fellow PA or med-minded friend. You can also follow us on Instagram at Joint Effort PAs for updates and extra content. See you next time.